Good afternoon, my dear students. I'm very glad to have a lecture today because it is a lecture after more than a month's period of stopping of education in Karazin University, and today I have a first lecture for third-year students. Unfortunately, from 24 of February, due to Russian aggression in our country, started the war. And from this day, the education in university was stopped. And during this period you did not have any classes, but 1 week ago a university decided to renovate your education in distant in online format, because it is a principal question for us for staying university, Karazin University in Kharkiv, and it was decision of all university to leave university in Kharkiv. And now, not to lose a study year, not to lose your studying your semester, we decided to renovate education and renovate your studying. And today I'm glad to have the first lecture for third-year students from MA groups after this stopping period. All missed lectures according to thematic plan you can find in my channel. It is recordings from the previous year, and all the topics you can work with my lecture from previous year. All topics you can find there. And today, according to our thematic plan, we continue education, and our today's topic is signs and symptoms of endocrine organs diseases and metabolic disorders. And according to your thematic plan, the lecture have to be about diabetes mellitus. But I want to include in this lecture, according to online format, I have a little bit more time. That's why I include two main topics. It is diseases of thyroid gland, like the most often endocrine disorders in general in most countries, and I include disorders of endocrine pancreas, and it is especially diabetes mellitus. Plan of our today's lecture, it is to give definition of endocrine system. I hope you remember it from physiology, but we should repeat. It is discuss spectrum of endocrine diseases and metabolic disorders. And we have two big parts. I will be quite quick because it is a lot of information for today. First part of lecture will be about thyroid gland disorders. Yes, we will remind how do thyroid gland works. It is history taken, it is patient's examination, clinical laboratory instrumental, and symptoms and syndromes of thyroid gland disorders. And function of endocrine pancreas. To remind how do pancreas works, history taking, patient's examination, clinical laboratory instrumental, and discuss symptoms and syndromes of disorders of endocrine pancreas. Let's give definition in general, repeat definition in general. What is endocrine system? The endocrine system, it is a group of glands or organs that regulate physiological functions by releasing hormones into the bloodstream. Hormones are chemicals can carry information to different parts of the body. Specific hormones influence certain organs or part of the body, such as the liver or pancreas. The endocrine system regulates development and growth, for example, puberty, metabolism, sexual and reproductive processes. It includes the reproductive glands, adrenal glands, thyroid glands, hypothalamus, pancreas, and pituitary glands. Although distinct from the nervous system through the hypothalamus, which regulates the pituitary gland function. The word endocrine derives from the Greek word endo, meaning within, or krinis, and krinis, meaning to secrete. Okay, what the spectrum? We discuss what glands can be in the endocrine system, and in each gland can be different disorders. In adrenal gland, it can be adrenal insufficiency or adrenal hormone excess. It can be in reproductive glands, congenital, it's for adrenal too, congenital adrenal hyperplasia and adrenocortical carcinoma. In glucose homeostasis disorders, we can see diabetes mellitus or hypoglycemia. Thyroid disorders include goiter, hyperthyroidism, hypothyroidism, thyroiditis, thyroid cancer, thyroid hormone resistance. In calcium homeostasis disorders and metabolic bone diseases, we can include hyperparathyroidism, hypoparathyroidism, pseudohypoparathyroidism, osteoporosis, and osteitis deformans. Moreover, we can include here rickets and osteomalacia. Pituitary gland disorders. It is posterior pituitary diabetes insipidus. In anterior pituitary, it is hypopituitarism, pituitary tumors, hyperprolactinemia, acromegaly, gigantism, Cushing disease, growth failure, and dwarfism. Sex hormone disorders. Disorders of sex development, hypogonadism, disorders of puberty, and menstrual function disorders. Tumors of the endocrine glands not mentioned elsewhere, multiple endocrine neoplasia or carcinoid syndrome. This big spectrum of disorders you will learn more detailed on endocrine cycle next year on 4th course. It started from this cycle, and today signs and symptoms, the main disorders and main symptoms of thyroid gland and endocrine pancreas. What about thyroid gland? Here is a picture with reminding the position of thyroid gland, its anatomy, topographical anatomy, and I hope you remember physiology. The primary function of thyroid is production of hormones T3, T4, and calcitonin. Up to 80% of T4 is converted to T3 by organs such as liver, kidney, and spleen. T3 is several times more powerful than T4, which is largely a prohormone, perhaps 4 or even 10 times more active. The production of T3, T4 is regulated by thyroid stimulating hormone, released by the anterior pituitary. The thyroid and thyrotropes form of negative feedback loop. TSH production is suppressed when T4 levels are high. I several times explained you what is negative, biological negative feedback. It is the opposite relation between hormones. And the most interesting example of it is thyroid hormones. Yes, relation between T3, T4 and TSH. When physiologically in normal health person, when T3, T4 decreased, it stimulates production and increase TSH. And opposite, when T3, T4 are high, it suppresses secretion of TSH and it decreases TSH. When T4 high, TSH low, T4 low, TSH high. This opposite relation we name negative feedback. T3, T4 act on nearly every cell in the body to increase a basal metabolic rate. First of all, it affects metabolism of different nutrients. It affects protein synthesis, help regulate long bone growth and neural maturation, and increase the body's sensitivity to catecholamines and permissiveness. T3, T4 are essential to proper development and differentiation of all cells in the human's body. T3, T4 also regulate protein, fat, and carbohydrate metabolism, affecting how human cells use energetic compounds. They also stimulate vitamin metabolism. Numerous physiological and pathological stimuli influence T3, T4 synthesis. T3, T4 leads to head generation in humans. And one more reminding. Here is a scheme of processes of iodinization of tyrosine when it is include 4 molecules of iodine. It formates thyroxine or T4 when it includes 3 molecules of iodine. It leads to formation of 3-iodothyronine or T3. The thyroid secretes about 80 milligrams of T4 but only 5 milligrams of T3 per day. T3 has a much greater biological activity, about 10 times than T4. An additional 25 milligrams per day of T3 is produced by peripheral monodiodinization of T4. And functional effects of T3 and T4 hormones on cardiovascular system. It increases heart rate, increase force of cardiac contraction, increase cardiac output, and upregulate catecholamine receptors. On respiratory system, it increase resting respiratory rate, increase minute ventilation, increase ventilatory response to hypercapnia and hypoxia. On renal system, it increase blood flow, increase glomerular filtration rate, in intermediary metabolism, increase glucose absorption from the GI tract, increase carbohydrate lipid and protein turnover, downregulate insulin receptors, and increase substrate availability. Effects on oxygen carrying capacity. It increases red blood cell mass, increase oxygen dissociation from hemoglobin. Effects on growth and tissue developments. There are increased growth and maturation of bone and tooth, increased growth and maturation of epidermis, hair, follicles, and nails. There are increased rate and force of skeletal muscle contraction, inhibits synthesis and increases dehydration of mucopolysaccharides and in subcutaneous tissue. Nervous system. Critical for normal central nervous system development. Enhances wakefulness, alertness, memory, and learning capacity. Requires for normal emotional tone. Increase speed and amplitude of peripheral nerve reflexes. Effects on reproductive system. They are required for normal follicular development, ovulation, maintenance of pregnancy in the female, spermatogenesis in the male. How thyroid stimulating hormone causes to release T4 and T3. The thyroid is controlled by hypothalamus and pituitary. It negative feedback, what I shortly told about. Through the feedback loop, the pituitary releases TRH, thyrotropin releasing hormone, which stimulates the release of TSH. TSH stimulates the thyroid gland to produce of the hormones T3, T4 and release into the blood. Purpose of investigation of patient with thyroid gland disorders. It is general evaluation of health, diagnosis of disease or disorders of thyroid gland, and diagnosis of other systemic diseases that affect thyroid gland function. First of all, of course, it is history taking and interviewing of patient. What should we ask? Main points in interviewing of patients with thyroid gland disorders. It is gathering of information, it is patient's narrative, it is biomedical perspective, psychological perspective, and context. During inspection, a normal thyroid is estimated to be nearly 10 grams with an upper limit of 20 grams. An enlarged thyroid is referred to as a goiter. There is no direct correlation between size and function of person with a goiter. Can be euthyroid, hypothyroid, and hyperthyroid. One more time, please pay attention to this information. The size of the gland and the function of the gland not related with each other. The big gland, the goiter, can produce enough hormones, excess hormones, or not enough hormones. And enlargement of thyroid gland, that we usually named goiter, we can classify according to World Health Organization on grades. Grade 0, it is no palpable or visible thyroid. Grade 1, it is palpable but not visible when the neck in the normal position. Thyroid nodules in the thyroid which is otherwise not enlarged fall into this category. Second, it is clearly visible in the neck, is in normal position, and is consistent with an enlarged thyroid when the neck is palpated. Laboratory examination. Biochemical examination of levels of thyroid hormones we name thyroid panel. What we include here? First of all, it is a thyroid stimulating hormone, or TSH. It evaluates overall thyroid function. For today, it is the simplest, it is the most useful test, especially for screening of patients for thyroid problems. And it is the first of hormones that responds on some problem. That's why we mean them like a most specific hormone. Moreover, we can check total thyroxine T4, evaluate the total amount of T4 produced in the thyroid gland. And free thyroxine, free T4, it is evaluate amount of T4 available for cells and tissues. Free T3 or triiodothyronine measures the amount of T3, the active form of hormone available to the cells and tissues. One more time, negative feedback between TSH and T4 by the skin. And levels of TSH, free T4, free or total T3 according to different problems. Yes, and according to negative feedback, for usual hypothyroidism, it will be high TSH and low T3, T4. For typical or clinical hyperthyroidism will be opposite. It is low TSH and high T3, T4. When I told you that TSH is the most sensitive, I mean that in some situation TSH can respond on problem in thyroid gland more earlier than T3, T4. In this case, level of TSH can be abnormal, low or high, but T3, T4 is still normal. Such situation we need subclinical, and according to level of TSH, it can be subclinical hypothyroidism when it is high TSH but still normal T3, T4, and subclinical hyperthyroidism when it is low TSH but still normal level T3, T4. And we have another situation when, for example, everything is low, low TSH, low or normal T4, and low T3. It will be non-thyroidal illness or rare pituitary or secondary hypothyroidism. And we have one more situation possible when it is normal TSH by high T3, T4. It's very rare situation, but possible too. We see such a picture in case of thyroid hormone resistance. Moreover, in blood we can check level of antibodies. What are the most usual antibodies for thyroid problems? It is thyroid peroxidase antibodies, thyroglobulin antibody, or TP or AB antiglobulins. And thyroid stimulating hormone receptor antibodies. We usually write them like TRAB. Okay, and here in what cases when it is ordered different types of antibodies. Who need stop this table? I don't have time for it. Visualization of thyroid gland, most often we do it with ultrasound or sonography, and here you can see picture of thyroid sonography. First picture, left picture, it is a normal structure, normal size. You see right lobe, left lobe. You see such a structure that you can see like a cyst, but by the arrow it shows that it is artery. It is the space of artery, looks like on this picture. And second picture, it is patient with partial thyroidectomy, when we can see a left lobe, but it is absent a right lobe of thyroid. According to Doppler sonography, we can check blood flow and velocity and volume of the blood flow in thyroid gland, and it gives you additional information. It can be radionuclear scanning, and you see the difference. For example, on first picture, it is normal accumulation of radionuclides in thyroid gland, and second picture, when it is much more intensive accumulation of radionuclides, it is typical for autoimmune thyroiditis, and especially like here in Graves' disease. In all not understandable situation, when it is present some nodules, when it is present some structures, we should do a biopsy of these structures of thyroid gland. And it looks like this. Yes, under the sonographic control, by one arm we control and visualize on monitor the structure of thyroid, and by second arm we make ejection, find this point of not understandable or some structures or some suspectable tissue for us, and take the piece of this tissue for investigation for biopsy. Okay, CT scans, we can do ultrasound, or not ultrasound, sorry, CT of thyroid gland, like here. ACG, typical problems in patients with thyroid gland disorders. It is cardiovascular disorders and especially arrhythmias. That's why always when we suspect something with thyroid, we always should do it ACG. And here on this picture you see a picture of arrhythmia. On first strip, it is arrhythmia. We name this arrhythmia atrial fibrillation. And second strip, it is normal sinus rhythm to compare with arrhythmic ACG. Okay, and let's discuss a little bit different types of dysfunction of thyroid gland. First type, and most often, it is hypothyroidism. It can be different, it can be primary and secondary, and let's discuss etiology of it. Primary. Most often disorders of thyroid in general, it is Hashimoto's thyroiditis, with or without goiter. On second place, it is radioactive iodine therapy for Graves' disease. It is iatrogenic problem due to treatment of Graves' disease. We do artificial insufficiency of thyroid hormones and hypothyroidism. Moreover, it can be post-surgical, like in subtotal thyroidectomy for Graves' disease or nodular goiter. It can be due to excessive iodine intake, due to subacute thyroiditis, and more rare causes like iodine deficiency, goitrogens such as lithium, antithyroid drug therapy, inborn errors of thyroid hormone synthesis. Secondary causes, when it goes more centrally for hypothalamus and pituitary gland. The main causes, it is hypopituitarism and tertiary or hypothalamic dysfunction. It is peripheral resistant to the action of thyroid hormone. Age aspects of hypothyroidism. Early onset in childhood lead to delayed or incomplete physical and mental development, maybe development of cretinism. When it is later onset in youth, it can lead to impaired physical growth. When it is adult onset, we name this situation, this disease, like myxedema. It is gradual changes occur: tiredness, lethargy, decrease metabolic rate, slowing of mental function and motor activity, cold intolerance, weight gain, goiter, hair loss, dry skin, eventually may result in coma. During iodine deficiency, thyroid hormone production decreases. TSH release increased, less negative feedback. TSH acts on thyroid, increasing blood flow and stimulating follicular cells and increasing colloid production, but the only result is that the follicles accumulate more and more unusable colloid. If goiter is due to decreased iodine, when thyroid gland enlarges, endemic or colloidal goiter, cells eventually die from overactivity and the gland atrophies. Cardiovascular. It is bradycardia, low voltage ACG, pericardial effusion, cardiomegaly, and hyperlipidemia. More, it can lead to constipation, ascites, weight gain, cold intolerance, roof, dry yellowish skin, puffy face and hands, hoarse, husky voice, respiratory failure. In female patients, it can lead to menorrhagia, infertility, hyper or prolactinemia. Renal disorders like impaired ability to excrete a water lot. It can lead to anemia due to impaired hemoglobin synthesis, iron deficiency due to menorrhagia and reduced intestinal absorption, folate deficiency due to impaired intestinal absorption, pernicious anemia. Neuromuscular, like muscle cramps, myotonia, slow reflexes, carpal tunnel syndrome, and from central nervous system it can be fatigue, lethargy, depression, inability to concentrate. Diagnosis of hypothyroidism we can do according to lab analysis due to free T4 and TSH for primary hypothyroidism. Hope you remember low T4 and high TSH. Serum T3 levels usually variable in hypothyroidism. It can be positive test for thyroid autoantibodies and enlarged thyroid gland like in Hashimoto thyroiditis. Free T4 and TSH inappropriately normal can be in myxedema. Absence of TSH response or TRH, pituitary deficiency. TSH, free T4 and free T3 are normal for subclinical hypothyroidism. High TSH but T3, T4 normal for subclinical. Okay, myxedema coma. It is emergency, medical emergency, which caused by end stage of untreated hypothyroidism. On the picture you see how it looks like this patient. The symptoms of it is progressive weakness, stupor, hypothermia, hypoventilation, hypoglycemia, hyponatremia, shock and death. The patient or a family member may recall previous thyroid diseases, radioiodine therapy or thyroidectomy. Gradual onset of lethargy progressing to stupor or coma. It can be marked hyperthermia with temperature of body less than 24 by Celsius. Heart failure, pneumonia, excessive fluid administration or narcotic. On ACG, typical bradycardia and low voltage of all waves. Usually, free T4 will be low, TSH high, normal or increased cholesterol, high or normal serum sodium. And opposite situation, hyperthyroidism, when it is excess of thyroid hormones. The second most prevalent endocrine disorder. Affects women 8 times more frequent than men. It may appear after the emotional shock, stress, or an infection. Graves' disease, excessive output of thyroid hormones. Other common causes of hyperthyroidism include thyroiditis and excessive ingestion of thyroid hormone, like in toxic adenoma or Plummer's disease or toxic multinodular goiter. Clinical symptoms of hyperthyroidism. From emotional balance, it is nervousness, irritability. It can be exophthalmos. It is a very specific eye symptom of hyperthyroidism. It can be goiter, like diffuse enlargement of thyroid and brood. It can be thyroid dermopathy, like pretibial mixed edema and decreased TSH and increased antibodies. It is heat intolerance. It is cardiovascular symptoms like palpitation, atrial fibrillation, chronic heart failure, dyspnea, angina. Gastrointestinal, like weight, appetite, diarrhea. Reproductive, it is amenorrhea, oligomenorrhea, infertility, and gynecomastia. Bone, it is osteoporosis and thyroid acropathy. Neuromuscular, like nervousness, tremor, emotional ability, proximal myopathy, myasthenia gravis, hyperreflexia, clonus, periodic hypokalemic paralysis. And from the skin, it typical pruritus, onycholysis, vitiligo, hair thinning, palmar erythema, and spider nevi. For diagnosis of hyperthyroidism, it is laboratory analysis too. Yes, here TSH will be decreased, but it is typical high free T4 and or high free T3. In eye signs are present, the diagnosis of Graves' disease can be made without further tests. If eye signs are absent and the patient is hyperthyroid with or without goiter, a radioiodine uptake test should be done. Radioiodine uptake and scan diffuse increased uptake. Antibodies is specific for Graves' disease, may be useful for apathetic hyperthyroid patients or who presents with unilateral exophthalmos without obvious signs or laboratory manifestations of Graves' disease. Occurs in a severely hyperthyroid patient caused by precipitating events such as infection, surgical stress, stopping antithyroid medication in Graves' disease. Clinical clues of medical emergency, the terminal stage of hyperthyroidism, thyroid storm or thyroid crisis. It will be fever and hyperthermia. It is marked anxiety or agitation that can lead to coma. It can be anorexia, tachycardia, tachyarrhythmias, pulmonary edema, cardiac failure, hypotension, shock, confusion. And it shortly all about endocrine, thyroid gland for today. It is the main things. As usual, if it is not understandable something, if you have question about this information or you need more information, please ask me on Facebook or here under the video in the comments. And let's continue our lecture with disorders of endocrine pancreas. And here the picture with reminding you anatomy of endocrine pancreas. Okay, it is sides, it's our old side. Okay, here is more actual information on our Facebook group. Okay, endocrine pancreas. Let's remind the primary functions of it. Production of pancreatic hormones by 3 cell types, glucagon by alpha cells, insulin by beta cells, and somatostatin by delta cells. Hormones travel through the bloodstream to target tissues. At the target cells, hormones bind specific receptors and cause cell changes that control metabolism. Reminder, the balance between insulin and glucagon. It is the opposite hormone that balancing each other and have the opposite effects. Like insulin have increase glucose oxidation, glycogen synthesis, fat synthesis, protein synthesis. It means that insulin synthesis accumulate everything, and glucagon the opposite effect has. It is destruct, it is provoke metabolism of all chemicals. It lead to glycogenolysis, gluconeogenesis and ketogenesis, and like in balance they regulate each other. Structure and role of insulin. Insulin, it is a polypeptide hormone composed of two chains, A and B chains. Both chains are derived from proinsulin or prohormone. Chains are joined by disulfide bonds. Acts on tissues to increase uptake of glucose and amino acids. It increases glycogen production, glucose storage in the liver and muscle. It stimulates lipid synthesis from free fatty acids and triglycerides in adipose tissues. Also stimulates potassium uptake by cells. Role in potassium homeostasis. Chemically, high levels of glucose and amino acids in the blood. Hormonally, beta cells are sensitive to several hormones that may inhibit or cause insulin secretion. Neurally, it is stimulation of parasympathetic nervous system cause insulin to be secreted. Insulin secretion is decreased by decreased glucose and increased insulin concentration in blood and sympathetic stimulation. Insulin transported through the blood to target tissues where it binds to target cell specific receptors and acts as biochemical signal to the inside of the cell. Cell metabolism is stimulated. The normal range, a narrow range of about from 3.9 to 5.5 millimole per liter, is measured by fasting glucose test or morning glucose before the breakfast. Hyperglycemia, it is high level of glucose. It can be short term, it can be normal like physiological hyperglycemia, and it can be pathological when it is more constant. Persistent, it is impaired like prediabetes, and high, especially for diabetes mellitus. Hypoglycemia, it is the opposite situation, that when blood glucose level low than normal, lower than 3.9. What the purpose of investigation of patient? It is general evaluation of health like for other endocrine disorders. It is diagnosis of disease and disorders of endocrine pancreas and diagnosis of other systemic diseases that affect endocrine pancreas. Patients interviewing have a target to gathering of information. It is patient's narrative, biomedical perspective, psychological perspective, and context. Clinical monitoring of diabetic complication, and here from the starting of this topic we discuss complication. Why? Because a huge number of people, you know that diabetes is one of the most often killers in all world, in all countries, but patients dying not from the high blood sugar, high blood glucose. Most of patients dying from the complications, and the most danger, the most symptomatic, the most problems in treatment, the most problem in diagnosis lying in complication. That's why we diabetes always discuss in a space of own clinic and at the same time complications too. Okay, what the clinical test we should do for checking diabetes and diabetic complications? First of all, it is blood pressure, management of blood pressure, monitoring hypertension and thus risk of heart disease. Eye examination, management, monitor onset and progression of eye disease. Foot examination, monitoring onset and progression of nerve disease and peripheral arterial disease. Indications for testing for diabetes in what people which should check it at all. According to American Diabetes Association, it is the most powerful and the most important diabetic organization in the world. We have such indications for testing for diabetes. First and the most important, it is obesity, when the body mass index more than 25 kilograms per meter in square. It is considered testing to detect prediabetes and type 2 diabetes mellitus in asymptomatic people. Family history of diabetes mellitus and first and second degree relative. Signs of insulin resistance or conditions associated with insulin resistance like acanthosis nigricans, hypertension, dyslipidemia, low birth weight. It indicated for patients with maternal history of diabetes mellitus or gestational diabetes. Even in children, they have risks for diabetes mellitus during gestation. What diabetic panel, what test, first of all, lab test we do for patients with suspected diabetes? It is CBC or complete blood count. It is glucose in serum, first of all, fasting glucose. It is oral glucose tolerance test. Now I will tell you what is that. Random blood glucose, islet cells antibody test for type 1 diabetes, hemoglobin A1C or glycated hemoglobin, and diabetic urea analysis. The current World Health Organization diagnostic criteria for diabetes should be maintained. Fasting plasma glucose more than 7 millimoles per liter or 126 milligrams per deciliter, or 200 plasma glucose more than 11.1 or 200 milligrams per deciliter. I promise you what the oral glucose tolerance test. It is when we do fasting glucose after 8 hours hunger in the morning before breakfast. We do check patient level of plasma glucose, fasting glucose, and after it we give a solution with 70 grams of glucose orally. Patient drink it, and in 2 hours we check one more time level of serum glucose, and normally it have to be 11.1 in millimole or not more than 200 in milligrams per deciliter. Glycated hemoglobin, it is one more very important diabetic test. If it is more than 6.5%, it say you about presence of diabetes mellitus. In level from 5.7 to 6.4, it is pre-diabetes or risk of diabetes. Glycated hemoglobin or hemoglobin A1C reflects average plasma glucose over the previous 2-3 months in a single measure, which can be performed at any time of the day and does not require any special preparation such as fasting. And table with the level of fasting plasma glucose, 2 hours oral glucose tolerance test, and glycated hemoglobin, what the normal for non-pregnant individuals and what normals for pregnant women. Who needed this information, please stop and fix right for yourself. Diabetic urea analysis. Glucose urea can be detected when level of blood glucose exceeds more than 11 millimoles per liter. It is a quite high level of glucose. It is a renal level, but before it is glucose not filtered in a glucose not filter in urine, and if it is higher than a level, it is presence of filtration of glucose in the urine, not enough reabsorption from the urine, and that's why we can see clinical glucoseuria. Urine test can be used alone to confirm the diagnosis of diabetes mellitus. They are always like a help, they are always additional for diagnosing of diabetes mellitus, additional to blood test. They are ordered more often there is suspicion of type 1 diabetes mellitus. For type 1 they are more important because they are very specific for ketones or ketonuria. Laboratories can test urine for ketone bodies, or even individually at home patient can control a level of ketones in urine. The body produces ketone bodies when fat tissues is used for energy instead of blood sugar. If ketone bodies are present in the urine, this could indicate the high level of glucose in the blood with insufficient level of insulin production. It was about ketones, about individual monitoring of glucose. All patients, the diabetes mellitus, it is a non-treatable disease, and patients suffer it from during all their lives. That's why they need to control their situation, their glycemia, not just in laboratory in hospital, but individually at home. And the simplest methodic, it is individual glucose measures. They looks like this, like on this picture. You see, it is such device which make a very small injection of the figure to take just one drop of blood, and such a test paper strip. Patient put their blood on this strip, and the device shows the level of glycemia. Okay, and more modern systems for monitoring, it is continuous glucose monitors. Continuous glucose monitors contain subcutaneous sensor that measure interstitial glucose levels every 1-5 minutes, providing alarms when glucose levels are too high or too low, or are rapidly rising or falling. See, it looks like this. It is less than smartphone with a small catheter that fixed subcutaneously. This catheter changed every several days, and this device sends signals. It can send signal to smartphone, to watches, with a level of glucose, and when it is too high or too low, it makes some alarm. Okay, diabetes mellitus. You remember, according to World Health Organization, the most often it is type 1, type 2, another type it is gestational diabetes, and more rare types of diabetes or secondary diabetes, other types of diabetes. More information on endocrinology and on practical class. Okay, what is type 1? Diabetes mellitus type 1 results from the body's failure to produce enough insulin. It is when the pancreas is unable to produce insulin. Main risk factor. It is viruses and toxins that can affect genetically determined antigens of HLA system and cause autoimmune destruction of beta cells in the islets of lung organs. Type 2 diabetes begins when the insulin resistance, a condition in which cells fail to respond to insulin properly. When it is okay with function of pancreas, it is able to produce insulin, it is enough insulin, but cells are not able to sense correctly, to feel correctly this insulin and respond to it with normal transportation of glucose. In the disease progression, a lack of insulin may also develop, yes, during some time, usually it is years, insulin deficiency, secondary insulin deficiency can be even in type 2. This form was previously referred as non-insulin dependent diabetes mellitus or adult onset diabetes. You know that type 1 more usual for children and young people, type 2 more usual for aged people. But for today, these limits are every year we see more and more young type 2 and age type 1. That's why it's not a very correct numbers, adult and young diabetes. The primary cause is excessive body weight and lack of exercise. And type 3 between orphan types, it is gestational diabetes. It is the third main form and occurs when pregnant women without previous history of diabetes develop a high blood glucose level. Classic clinical symptoms. I told you that general clinical picture mostly produced not by the diabetes and hyperglycemia. It is referred to complications, but hyperglycemia has its own symptoms. We name it classic diabetic symptoms. What is that? It is 3 poly. It is polyphagia or increased hunger, polyuria, frequent urination, polydipsia, increased thirst. Other symptoms, they are referred for hyperglycemia too, but not such a significant. It is blurred vision, it is fatigue, it is can be weight loss or weight gain according to type of diabetes. It is poor wound healing, like for cuts, scrapes, etc. It is dry mouth, dry or itchy skin. It can be impotence in male. It can be recurrent infections such as vaginal yeast infection, groin rash, or external ear infections like swimmer's ear. Early and late clinical symptoms. Early symptoms. It is frequent urination, increased thirst, blurred vision, fatigue, headache. And more later, mostly in type 1, they are referred to ketoacidosis. It is fruity smelling breath, nausea and vomiting, shortness of breath, dry mouth, weakness, confusion, coma, abdominal pain. And one more time, early and late clinical symptoms in pictures. What is that? It is weight loss, it is extreme tiredness, it is increased hunger, excessive thirst, frequent urination, tingling and numbness, blurred vision, unhealed wound, and, like for fun, urine approaching ends. And for your objective investigations, system by system, organ by organ, one more time symptoms. From central nervous system, polydipsia, polyphagia, and more usual for type 1, lethargy and stupor. Eyes, it is blurred vision for both types. Breath, smell of acetone, more for type 1. Systemic weight loss, more for type 1. For type 2, more usual weight gain. Respiratory system, here for type 1, usual Kussmaul breathing or hyperventilation. GI symptoms, nausea, vomiting, abdominal pain, they are more usual for type 1 diabetes and ketoacidosis. And urinary symptoms, polyuria, glucoseuria, they are possible the same for both types of diabetes. What is diabetic ketoacidosis or DKA? It is one of the most often acute complications of diabetes mellitus. A potentially life-threatening complication happens in patients with diabetes mellitus type 1, but in some cases you can discuss on practical classes in which it can occur in those with diabetes mellitus type 2. The symptoms usually evolve over the period of about 24 hours. Predominant symptoms are nausea and vomiting, pronounced thirst, excessive urine production, and abdominal pain. Breathing becomes labored and of a deep, gasping character, like Kussmaul respiration. In severe cases, there may be confusion, lethargy, stupor, and even coma. On physical exam, there is evidence of dehydration, like tachycardia, low blood pressure, ketotic odor, and death. Blood analysis will reveal significant decrease of pH less than 7.3 millimoles per liter. Urine analysis will reveal significant level of ketone bodies, often before our other overt symptoms. Other acute complication, it is non-ketotic hyperosmolar state. An acute complication sharing many symptoms with diabetic ketoacidosis, but an entirely different origin. Water osmotically drawn out of cells into the blood. The kidneys eventually begin to dump glucose into the urine. Serum pH will be more than 7.3. It is non-ketotic and non-acidotic. Bicarbonates more than 15 milliequals per liter, normal 2. Small ketone urea and absent to low ketone amia. Increased risk of blood clot formation. If fluid is not replaced, the osmotic effect of high glucose levels combined with the loss of water will eventually lead to dehydration. Some alterations in consciousness lethargy may be ultimately progress to a coma. Okay, acute complications. Let's discuss comas. It is terminal emergency situation. A life-threatening of diabetes mellitus complication that causes unconsciousness. 3 different types. It is severe low blood sugar in diabetes mellitus person or hypoglycemic coma. It is diabetic ketoacidosis advanced enough to result in consciousness from combination of severely increased blood sugar level, dehydration, and shock and exhaustion. And hyperosmolar non-ketotic coma, in which an extremely high blood sugar level and dehydration alone are sufficient to cause unconsciousness. But if patient with non-ketotic hyperosmolar state in coma, it is the most severe situation. Here mortality near 70%. Very, very serious situation and very difficult to manage. Diabetic coma was a diagnostic problem before the late 1970s when glucometers and rapid blood chemistry analyzers became universally available in hospitals. Okay, and situation that we did not discuss, it is hypoglycemia. A medical emergency that involves an abnormally diminished content of glucose in the blood. Symptoms of hypoglycemia usually do not occur until 2.8 to 3.0 millimoles per liter. Adrenergic manifestation. It is shakiness, anxiety, nervousness, palpitations, tachycardia, sweating, pallor, coldness, clamminess, mydriasis. Glucagon manifestation. It is hunger, nausea, vomiting, abdominal discomfort, headache. Neuroglycopenic manifestations. It is abnormal thinking, depression, crying, exaggerated concerns, paresthesia, negativism, emotional lability, fatigue, weakness, apathy, lethargy, daydreaming, confusion, amnesia, blurred vision, automatic behavior, difficulty speaking, incoordination, motor deficit, paresthesia, headache, stupor, coma, etc. And let's discuss chronic complication very rapidly, very shortly. Chronic complication of diabetes. All of them we can divide on vascular and neurological. Vascular we can divide on microvascular complications and macrovascular complication according to size of vessels that was affected by diabetes. What is microvascular complication? It is diabetic cardiomyopathy, diabetic nephropathy, diabetic neuropathy, diabetic retinopathy, and diabetic encephalopathy. Macrovascular, it is coronary artery disease, diabetic myonecrosis, peripheral vascular disease, and stroke. Other types of chronic complications. It is GI, like gastroparesis, diarrhea. There goes in a result of neuropathy, diabetic neuropathy. It can be genitourinary, like uropathy, sexual dysfunction. They can be dermatologic, infections, cataracts, glaucoma, periodontal. It is just the main, it is a huge number of different complications, and it was just the most often of them. Yes, and here you see by the pictures the most danger and unfortunately one of the most often complications of diabetes. It is most often causes a toll in internal medicine of hospitalizations, of morbidity, of mortality, etc. What is it for diabetes? It is blindness, it is kidney failure, it is heart attack, and amputations due to diabetic food. Diabetic retinopathy results like a main cause of blindness. Results in a scattered hemorrhages, yellow exudates, and neovascularization. This patient has a neovascular vessel proliferating from the optic disc, requiring urgent pararetinal laser photocoagulation. And let's return one more time. I want to return. It is a finishing of our lecture to hypoglycemia. Why I want to return? Because it is the most often emergency in endocrinology, in diabetology, and one of the most often in general internal medicine. Because a huge number of patients with diabetes, a huge number of patients on insulin who are the most sensitive for this situation. That's why every person, for doctors, for all medical staff, and even not medical workers, we should know clinical picture and first aid for hypoglycemic state, because it goes in minute and some patients even don't have a chance to go to the hospital. And if patient unconscious, sometimes just people in the street should do some help for this person, and that's why every person, medic or non-medic, should know what to do. Hypoglycemia, one more time, it is low blood sugar, common in patients with diabetes, but most cases are mild and not considered a medical emergencies. Effects can range from feeling unease, sweating, trembling, and increased appetite. In mild cases to more serious, such as confusion, aggressiveness, seizures, unconsciousness, and rarely permanent brain damage and death in severe cases. Symptoms of low blood sugar. By the pictures, it is shaking, sweating, anxious, dizziness, hunger, fast heartbeat, impaired vision, weakness and fatigue, headache, and irritable. It is the most often most important symptoms in pictures. By the nature, by the origin, we discussed already all these symptoms. That's why if you see person with these symptoms, if you have a chance to ask about history of diabetes, you should do something. And what to do? If patient is conscious, give something sweetie, ideally some sweet drinks like cola or juice or tea with a sugar or any other sweet drinks or chocolate or something sweetie. And if patient already unconscious, it just glucose, 40% solution of glucose IV. For today, it is all material what I want to talk to you. It was very short, because endocrinology, it is a big science. It is a lot of information, much more information in thyroid gland disorder, much more information about diabetes mellitus. But main points as for introduction, like for propaedeutics, I try to give you. If you have questions, if you have not understandable or some difficult moments in diagnosis, in symptoms, in complication, diabetology, it's quite difficult to science, you can ask us in our closed Facebook page under this video. You can write directly for me or for your practical class teachers, or you can write your questions in comments under this video on YouTube. And of course, as usual, I want to write you your name and group in comments under the video for my individual controlling who listening my lecture. And for today, that's all. See you on the next lecture. Next lecture will be about signs and symptoms of excretory system disorders. It will be interesting lecture too. That's why see you in 2 weeks, and for today that's all. Good luck for you, stay safe, and goodbye.